Welcome back, everyone, to Rockefeller College's Lunch and Learn lecture series. Today's talk is titled Where Next for Health Reform? Implications of Trump 2.0 for Health Policy in New York State. And we are privileged to be joined today by Ashley Fox and Roland Poirier. I hope I pronounced your name right, Roland. Um, Dr. Fox is an associate professor here at Rockefeller College whose research specializes in global health policy. Roland Poirier is a member of the Sachs policy group and specializes in public budgeting and finance, actuarial rate setting, and healthcare policy. Before I pass it over to our speakers today, as always, ground rules. We're going to spend maybe a little over half of today going through Dr. Fox and Roland's presentations. After that, we were going to transition to Q&A. So if you have any questions at any point today during the talk, you can just put those in the chat and I will read them to both of our presenters. Anyway, I will pass it over to our speakers.
Great. Well, I'm going to start us off here. Good afternoon, everyone. And I'm going to try to keep this to 20 minutes. There's a lot to cover, but thank you all for being here and thank you to the organizers. We have such a limited time today and it's such a critical topic. I'm really only going to be able to scratch the surface. So we're going to dive right in. So I'm going to try to cover Trump's recent cuts to public health and NIH funding. And then Roland is going to cover some of the looming cuts to Medicare and Medicaid and some of the implications of that. And then we'll take your questions. So first I want to give a brief bit of background about how we kind of got where we are today. There were several key developments prior to Trump taking office that gave a sense of where health policy might be headed under Trump 2.0. So I'll try to take us through a couple of those. So first of all is the development of what eventually has come to be called Make America Healthy Again, right? The Make America Healthy Again movement with RFK Jr. as its leader. And so I don't have a lot of time to go into this, but basically RFK has been quite successful at drawing on people's legitimate concerns about how money in politics and state capture might be contributing to sort of our toxic health and food environments. And some of his ideas about food additives and pesticides and the harms of industrial agriculture are, broadly accepted in the public health community and backed by legitimate research. But he's kind of harnessed some of these legitimate concerns towards a lot of discredited ideas that really have no basis in science, blurring the lines between, sort of real and fake news and research. In addition to that was the publication of Project 2025 that essentially provided a policy blueprint for what Trump might tackle in his second term. This was written by the Heritage Foundation. And health and healthcare was featured prominently in this document and a key target for reform, including extensive reforms that were outlined to the National Institutes of Health, the CDC, and FDA, as well as massive restructuring of Medicare and Medicaid. So I think we had a pretty good idea of what he might be planning in his second term in regards to health. And then more recently, Trump announced the creation of the Department of Government Efficiency, or DOGE, which was originally to be headed by Elon Musk and Vivek Ramaswamy before Vivek was sort of taken out of the equation, leaving just Elon Musk at the helm. And so at first, I think this maybe didn't sound so bad. Most people, agree that the government could do things more efficiently. But it was, kind of quite unclear what the mandate of the agency this agency that was created by an executive order was going to be and whether it was even really legal. But it has quickly become apparent that DOGE's main task is not so much to, as the metaphor is going, take a scalpel, but rather, taking more of a sledgehammer approach to bulldozing the size of the federal government, with seemingly very little regard for, a lot of the programs that are being cut or, really trying to achieve efficiency goals. And I don't think that's a particularly controversial statement that, there's been a lot of reporting on that. And the goal of this is actually to find money in the budget to fund very large tax cuts. So the rest of the talk is basically going to be kind of outlining just how big and damaging DOGE's sledgehammer approach is to specifically healthcare and to some of the reverberations throughout the health sector that this may create. And I will say both the public health sector, but also private health sector as well. So on that note, first I want to give a sense of the magnitude of the size of the health sector in the US, because it really is a huge share of the US economy. Health is nearly 20% of the GDP in the US, and the US spent almost $5 trillion on healthcare in 2024. Now that's total health expenditure. That includes public and private health expenditure. And if we look at, public and private health expenditure, it's actually almost equally split. So in 2024, private health expenditure was about $2.7 trillion. Public health expenditure was about 2.1 trillion. And most of that is coming from Medicare, Medicaid, and other kind of public health insurance, including the VA. So now I want to just sort of dissect a little bit more the budget and where health kind of fits into our overall federal budget. But the main point that I want to make here is that health is a really large share of the federal budget, and it's probably for that reason why it's facing some of the largest cuts. But again, I want to emphasize that this is going to have devastating ripple effects throughout the economy, right? And it's not going to be limited to people with public insurance, but can also have significant impacts on people with private insurance as well. So I'm not going to go into this piece because Roland is going to cover this, but just to say that one of the biggest shares of our sort of mandatory spending is, on essentially Medicare and Medicaid, which combined are about $1.6 trillion. And then when we add to that the VA, that's another $370 billion. Well, that's for the total for the VA budget, but about 88% of that goes to healthcare for veterans. So that's where the largest share of our health spending comes from. But in addition to that, down here, sort of hidden under science and medical research, which is really only 1% of our total federal spending, is the National Institutes of Health and a much smaller sliver, the AHRQ, the Agency for Healthcare Research and Quality. And this is where a lot of our, funding for medical research comes from. So the NIH in 2024 has or had, depending on how you want to look at it, an annual budget of nearly $48 billion. And that makes it the largest public funder of biomedical research in the world. So again, what we find from the NIH has spillover effects to healthcare, globally as well. Much, much smaller, of course, is the Agency for Healthcare Research and Quality, which is just in the millions of dollars, but it provides funding for improvements in health service delivery, such as how we can make healthcare more efficient and better delivered. And I'll just preview in case I don't get there, the AHRQ stands to be almost completely eliminated presently. In addition to that, I believe, I don't know exactly how the Center for Budget and Policy Priorities categorizes things, but I think that the CDC and SAMHSA and some other health agencies would probably go under all other. So the CDC has an annual budget of about $12 billion. And of course, we're all familiar with what the CDC does from the coronavirus pandemic that we all lived through. And SAMHSA is the Substance Abuse and Mental Health Services Administration. Its budget is about $7.5 billion, and it oversees the promotion of mental health and the prevention of substance use and support for recovery. So these are all, really critical public services. And I also put SNAP in here because of the critical overlap between food insecurity and, sort of all things related to food and agriculture and health. And it also is facing very substantial cuts, and its budget is about $113 billion. So just pointing this out to say that these are all really critical services that are, facing very significant cuts and don't necessarily comprise a ton of money when we put this in like the broader perspective, right? And then I also want to mention USAID, which would probably fall under international here. It had a total budget of about $40 billion. And about $8 to $12 billion of that went towards global health initiatives. And those are being almost completely eliminated with some exceptions for like HIV prevention and care. So I also want to spend a bit of time highlighting the cuts to the National Institutes of Health. Ideally, we might have even another lunch and learn session about this because we could definitely have a whole session about this and its implications, but just try to really briefly give an overview here. I think even what was outlined in Project 2025, so far what has happened seems, to go beyond what was outlined there or what anyone was really anticipating. So just to give a sense of what has happened. So initially back in January, there was like a pause on peer review that happened. And people were concerned, but it seemed like the government was just trying to, assess its priorities. But since that time, there hasn't been a single new notice issued since January of 2025, and council has not met since January, which is what would give the next round of grants, although it's due to meet in April. But the most concerning, well, there's many concerning things, but one of the most concerning is this proposed cap of 15% on indirects for all federal NIH grants. And this may sound like a kind of wonky, obscure issue. Then you might say like, well, why should I care about this? But it actually is probably the thing that could have the most devastating impact on our research infrastructure across the board, not just for health, but for all research. So essentially, for people who maybe aren't aware how this works, NIH subsidizes the entire research ecosystem of Research One universities, right? Because through these indirects. So, if you, for instance, are a social scientist, maybe you tend to get smaller and less frequent grants, maybe not from NIH, but the whole research infrastructure at the university is subsidized by the indirects from these NIH grants. And so, even though it may seem like a kind of bizarre and perverse way of funding things, it actually works, and it, allows us to have this robust, academic research institutions. So by cutting this, we are really doing significant damage, not even just to our public health research or, biomedical research, but to research more generally and to Research One institutions. And so in addition to that, there have been cuts to specific types of grants, right? This includes basically all grants related to vaccine hesitancy, to my understanding, have been terminated. And grants that contain certain words, I've put kind of a list of what some of these words are over here, have been targeted for termination, and especially any grants containing language around equity and inclusion have many of them have already received cancellation notices. By some estimates, at least 300 grants have been canceled so far. In more targeted cancellations. And as far as I know, all F31 diversity supplements have been canceled. These are supplements to funded grants that are a major way of funding PhD students. Basically, they allow you to fund PhD students from diverse backgrounds to work on your grant. In addition to that, there have been the kind of targeted retaliatory cuts to specific institutions, right? And so the first that we saw of this was Columbia with $400 million in grants cancellation. And, essentially, in order to get back this grant funding, they were being asked to, require have an increased police presence, ban masks and require the expulsion of certain students and taking on certain departments into academic receivership. Johns Hopkins is facing a similar threat of, $800 million in canceled grants. University of Maine is facing cancellations of $100 million in grants. So that's just to give, a sense. And I think I'll try to come back to this, but, there are much broader implications here, even beyond just the lost, research funds for scientific independence, for, the overall climate of free speech and academic freedom on campuses that are at stake. In terms of other health agencies, right, there's also a lot of cuts coming in general for our public health infrastructure. So HHS, by some estimates, so this is the sort of umbrella organization for other parts of our health infrastructure, could be facing as many as 20,000 layoffs in total. The VA is being faced with a reduced budget of 22% and asked to cut 80,000 employees. 3,500 employees have been laid off from the FDA, and this includes the sort of forced resignation of Peter Marks, who is a leading vaccine official and headed up Operation Warp Speed. And we recently saw the appointment of David Geyer to lead a federal study examining potential links between vaccines and autism. David Geyer is a known vaccine skeptic. At the CDC, there are plans to cut 10,000 jobs, including, I may not get here, but the whole HIV prevention section of the CDC may be significantly reduced or eliminated. And that's in addition to 10,000 people that have sort of voluntarily left. These cuts just came down the line. Local health departments are facing $12 billion in funding cuts to state health departments and $10,000 job cut. Anyone who knows about local health departments knows that they're already sorely understaffed and not enough resources. I'll just keep going here with some more cuts. So SAMHSA is facing about 50% cut to its staff. So from 900 to about 450 and $1 billion in grants. And again, this is like the main way that we fund mental health and, substance use. And we're in the midst of a mental health and substance use crisis. The Administration for Community Living, which sort of oversees nursing home care for older adults, is facing deep cuts apparently. And the Agency for Healthcare Research and Quality, as I mentioned, is a major agency that actually tries to fund research on how can we make healthcare more efficient and effective for people. And it's facing almost total elimination with reduced staff of about 80 to 90%. CDC is dismantling the division of HIV, and by some estimates, people have started looking into this. It could increase HIV infections by as much as 143,000 cases. There's also massive cuts to global health. The cuts to USAID have been devastating to global health. Much of PEPFAR, the President's Emergency Fund for AIDS Relief in Africa, was dismantled. This was actually a program that was put in place under George W. Bush, but it does seem that maybe some of these grants to medications to treat HIV and TB and food aid in places affected by civil war and natural disasters might continue, but almost all of the global health infrastructure of USAID has been dismantled. In addition to that, we just recently found out that Gavi, the Global Alliance for Vaccines and Immunizations, will be the $2.6 billion grant that the U.S. had made to it that would run through 2030 has been eliminated. Gavi is estimated to have saved the lives of 19 million children since it was set up 25 years ago, and the U.S. contributes 13% of its budget. I'm going to skip over, these are just some examples of canceled grants. One of my grants was canceled, actually. The PI was at Columbia. We were studying the effects of postpartum Medicaid extensions on maternal health outcomes, but it had the word equity in it. And so that grant was one of the ones that was targeted. And this is just some of the language that has been used to just, in the notices that are sent out about the grant cancellations. I won't get into that, but some of it sounds very kind of dystopian. I just also want to highlight, and then I'm going to start wrapping up because I know I'm really short on time here. Another big challenge is that major data collection efforts have been put on hold. It's unclear currently whether they're going to resume. They're currently on pause. If you look at their websites, they say that they're being modified and they're on pause. So this includes the Pregnancy Risk Assessment Monitoring System, or PRAMS, which is the main way that we know about maternal morbidity and mortality in the US, the Behavioral Risk Factor Surveillance System and the Youth Risk Behavior Survey. This is how we know about just basic public health behaviors. Are people eating their fresh fruits and vegetables? Are they getting their diet and, proper exercise? But also things like teen suicide or suicidality. We learn from these kinds of things. Demographic and health surveys, that's our main source of population data globally. People use this all around the world. I use this in my research all the time. My dissertation was written from it. So even the means to do research and to analyze the impacts of these cuts on public health, are being put on hold and possibly eliminated. And just to kind of conclude, this is really getting to the end. So I wanted to come to impacts on New York State. There's been some efforts, this is like all very new, to document the extent of the economic impact and other impacts from these grant cuts. So this team at Science Impacts of researchers has estimated that cuts to the NIH could result in $16 billion in lost economic activity and almost 69,000 job loss. And they actually are looking at this on a state-by-state basis. So for New York State, they predict a $1.7 billion loss and a loss of almost 8,000 jobs. I just read this in the Gothamist this morning that New York State stands to lose more than 360 million as a result of cuts to federal health grants. 27 million to the State Office of Mental Health, 40 million for the Office of Addiction Services and Supports, 300 million for the State Department of Health. And in terms of global health, again, this is just going to be devastating for our pandemic preparedness efforts. There are estimates that UN foreign assistance saves approximately 3.3 million people a year. And from the Gavi cuts, that 75 million children won't receive vaccines in the next 5 years, and 1.2 million could die as a result. So just to sum up in terms of what we can actually do, I don't know. I look to everyone else out there, what can we do? But I think some of the things that are pending, we've got legal challenges in the works. There's questionable legality about all of this. Obviously we can urge congressional action. In theory, Congress still controls the power of the purse. On a personal level, we can do more public mobilization and advocacy. States and localities may need to take up more of the slack. Roland's going to talk more about that. And universities and businesses and other people and groups that are affected could come together and try to, resist collectively in various ways, although so far that hasn't really been happening. Columbia sort of took a buyout deal, for instance, rather than actually come together to combat this. So I'm going to stop there on that very depressing note, and I'm going to turn it over to Roland.
Yeah, it's depressing to put these together and present them from the perspective of public funding for health. And so yeah, I'm going to pull up my slides. They're way less aesthetically pleasing than Professor Fox's slides, but hopefully they're still helpful. Okay, yeah. So I was sort of tasked with understanding that there's way too much to really cover in one presentation. We thought we could divide and conquer, and I was going to focus mostly on Medicaid and what's been happening and what might be coming from Medicaid. Those were some nice stats on public health expenditures, through major federal programs. I think one of the interesting ways to sort of break this down is what has happened so far and what are we anticipating that might happen in the coming months, weeks or months. And so, to date, there have been a few things, mostly administrative. One major congressional action. Most of these are probably on folks' radar already. There were a number of executive orders impacting a wide swath of government activity from the executive branch. I think the two that were most impactful so far to Medicaid were these focused on limiting gender affirming care and elective abortions, and so attempting to limit the federal funding for both of those services. So those are partially stayed being litigated, but that would cut vital funding to these services from the Medicaid program and the Medicare program. People don't think of Medicare as impacting youth, but there are a lot of individuals with disabilities, both intellectual and physical disabilities, on Medicare as well, that rely on that program. It's a big part of that program, so that would be impactful there too. HHS reorganization, Professor Fox mentioned, that's happening, and so they're looking to cut 10,000 employees. They're consolidating divisions from 28 to 15, and they closed 5 regional offices. As someone who's worked in and around Medicaid for a long time, those regional offices do a lot of the blocking and tackling that just makes the program kind of work, from administrative reviews of funding applications or adding new services or these sorts of things. A lot of that happens outside of the political world, and they happen in the administrative world. closing an office like New York City, they also closed Boston, which means that all of that work would now have to funnel through Philadelphia. If they went through with this, that would be a huge logjam, just for being able to run Medicaid. So that's something, we've been watching pretty closely. There are also proposed changes to the ACA regulations that have happened. So Trump's first term, a major focus was undermining the ACA. We're seeing them combat this with a more nuanced sort of approach now. So these regulations would tighten the enrollment period, put stricter income eligibility verifications on folks to receive ACA subsidies and funding, which are basically more red tape. I'm sure we have scholars on here that research government red tape that could tell you about that. And then removing, one of the important things here as well, is removing lawfully present status for the DACA population. So that's deferred action for childhood arrivals. And that's I think it's about 28 million people nationally that fall under that designation. It's pretty impactful in terms of the change. I think that's high, but it's at least tens of thousands in New York that would be impacted by that. And then the big thing that everyone's been watching is this budget reconciliation with Medicaid cuts. And so the context here is, at the end of this calendar year, the Trump tax cuts from the first term will expire. There's also proposals to increase tax cuts through other proposals that have been mentioned, such as non-taxes on tips and other things. In order to fund those cuts, they're looking for, or in order to fund the tax cuts, they're looking for deep spending cuts as well. And so the budget reconciliation passed by the House in February included a mandatory reduction of $2 trillion in spending across the entire government. That's over 10 years. So that's $200 billion a year. We're anticipating 880 billion of that, or 88 billion a year, coming from Medicaid. That's right around 15% of the federal Medicaid funding. And so that's going to be massively impactful to the populations that Medicaid supports. We're going to get into how they're going to achieve some of those funding cuts later. Important to note that the budget reconciliation bill doesn't mention how to achieve those cuts. It just directs the relevant committee in Congress, is the Energy and Commerce Committee, to find that funding. Another thing I wanted to point out here, though, is that the tax cuts are estimated at 4.5 trillion, and the savings are estimated at 2. And so this proposal, as passed in the House, would increase the deficit by 2.5 trillion. It's just interesting to hear some of the taglines about all this being about reducing the deficit, while we're only entertaining proposals that would further increase the deficit while cutting major programs as well. So just keep that in mind as you're hearing taglines about concerns about the deficit. And so, as I mentioned, the 880 billion over 10 years, we don't have the specific details from Congress on that. We do have a number of other things that have been proposed, either through Project 2025, through comments made by specific congressmen or senators, or Trump administration itself. And I think there's probably a handful, 5 or 6 proposals that are being passed around that are likely to be taken up with varying degrees of likelihood. I think 3 of them are the most important to probably bear in mind, and that's what I focused on here, or the big 3 proposals that I think are both incredibly impactful in terms of cuts to the Medicaid program, but also on the higher end of the likelihood spectrum of happening, based on some of the comments we've been hearing. So those are caps on federal matching funds, and we'll get into what that means. Work requirements as part of Medicaid eligibility. We'll talk about that. And then review of Medicaid financing mechanisms. This is some of the ways in which states fund their share, or the non-federal share of the Medicaid program, and limiting some activity there. Other things that are happening, in addition to everything that Professor Fox mentioned, and probably things that neither of us are going to have time to get to, there's going to be reviews of Medicaid waivers state by state, and Medicaid supplemental payments. A lot of activity in the Biden administration focused on equity, and some of those terms, those grant terms that Professor Fox mentioned, are being sought out and sort of eliminated. I think when it comes time for them to start focusing on these waivers, they're going to find similar programs that they're going to target. And so that's something that's going to happen as well outside of the legislative process. It's purely administrative. But limits on federal match percentages. So this is a sort of, as probably most folks are aware, the federal government funds a portion of Medicaid and the states fund a portion of Medicaid. The percentage funded by each party differs by state based on the per capita income of that state. So New York's standard match rate in New York is 50%. That ranges all the way up into, I think it's almost 80% in some of our lower income states of federal funding. But the proposals to change that have been sort of losing steam, I think. The main thing I think we're gonna see and have a discussion about is this idea of limiting the enhanced match. And so the biggest source of enhanced match right now, having a couple of COVID era programs ending, is still the ACA enhanced match for the childless adult population. So states that expanded Medicaid coverage received 100% match to begin, and then it phased down to 90% federal funding for childless adults. New York expanded prior to that, but still receives that funding for folks that they expanded. They call it the do-gooder provision. And so New York benefits from about 6.5 billion in additional funding from this population, federal funding. And so I think that's about 10% of what we would see nationally. So we'd be looking at around 600. Is there a number here? Actually, sorry. So if they were just to remove this provision, the estimate is that would save 690 billion nationally, and that would target those states that expanded Medicaid, which is most states at this point. But it gets back to that stated priority that the administration had in the past to undermine or undo the ACA. And so this would undo the extra federal funding for expanding the Medicaid population of the ACA. And as I mentioned in New York, this would be about a $6.5 billion hit per year, which is, a substantial portion of the Medicaid budget in New York State. The thing that, is most probably scary about this is how quickly it could happen if it passed in law. It's simply changing the amount of funding that is put up for $1 spent on Medicaid in a state. It's a purely administrative action that could be, accomplished pretty quickly once there were statute backing it up. So that one is one that would get them, almost 3/4 of their funding cuts, would go towards their policy goal of undermining the ACA, and would penalize blue leaning states more so than right leaning states. So that's what makes it kind of a concern. The other one that they talk about a lot is work requirements. And I know that there was recently another study put out on the potential impact of work requirements. I just saw it this morning. I don't think this is likely from a mandatory perspective across the entire Medicaid program. I think we'll see states apply for waivers to implement these work requirements in certain states. It's going to be particularly impactful for populations that are on other programs like SSI that qualify them for Medicaid, because while in the past they didn't have to do anything to obtain Medicaid, now they're going to have to follow additional red tape, meet work requirements and things. And so it could be as many as on a high end, if this were applied broadly, 1.5 million people losing Medicaid coverage and resulting in $11 billion in reduced spending per year. Again, that's a global number. So I don't think that's likely. I think it's more likely to happen on a state by state basis. But this is one that we'll see more of in the coming months. And then finally, this limiting, I'm going to call it creative non-federal funding for Medicaid. So as I mentioned, the states and local governments put up a share of Medicaid funding. This is something that's been a bipartisan target in the last couple of decades, frankly, where you have states, red and blue states, that you're using creative means such as provider taxes or intergovernmental transfers to cover their share of Medicaid. And so an example would be if, let's say in a state that's 50% federal match like New York, if the state were to put in place a tax on hospital inpatient revenue, for every dollar that tax brought into the state, 50 cents of that dollar would be paid by the federal government. And so as they increase that tax, while they're paying out 50 cents more, they're getting $1 in revenue, and the feds are contributing $1. And so you're seeing this happen across a variety of programs, and it's pretty ubiquitous. Texas is particularly good at this. New York and California most recently added a plan tax. So this is a tax on insurers, which has a similar effect. In the New York State budget, that generated $1.9 billion a year, both last year and this year. And spending, they're keeping it in the budget for next year. Although I suspect this will be targeted pretty strongly. Even the Biden administration basically said, okay, you got us on a loophole for that additional plan tax and that funding. We're going to close that loophole prior to their departure. So it's something, as I mentioned, is a bipartisan issue. The National Governors Association pretty strongly pushes back on this because governors rely on this funding, obviously, to support their budgets and increase benefits to populations that are served by Medicaid and other public health programs. So that'll be an interesting sort of back and forth, is to see the administration trying to put limits on this and how governors respond and push back. But the timing on this would vary. A lot of it, will come up when administrative items need review and approval from CMS. So like certain waivers need approval, or state directed payment programs need approval. And so they'll be able to handle those on a one-off basis. If they wanted to do something like a law or even a comprehensive regulation, that would take time to implement. And so I think it'd be unlikely to see that in the next year. But certainly, as I mentioned, as waivers come up, and certain aspects of the program that require federal approval to continue come up, I think we'll see this lens being applied to it. And there's a really good, not good, but a clear articulation of their perspective on this topic with that same kind of embellished language, aggressive language applied to it, that I could send around from the Paragon Institute on this topic as well. So just to finish up here, potential responses to these cuts if implemented. Essentially, as a state, you have three options. You could, limit benefits or coverage to populations. You could reduce prices, rates in the program, or you could look for additional revenue sources. I think that'll vary based on states. With the ACA funding, that 90% match, I believe it's 10, if not 11 states now have what they call trigger laws, where if the feds were to reduce funding below 90% for the healthy adults population, the childless adults population, I should say, the state will automatically disenroll those people from Medicaid. So it's already in law. It's automatic if the feds were to change. So that's millions of people that'll lose Medicaid. States like New York might take a more nuanced approach and look at finding ways to recover that funding and keep that population enrolled. In lieu of the losses of federal support. And so that's where you would look at some of these other options for how you would sustain a budget. You could see across the board spending cuts for services in the Medicaid program. You could see, pressure being put on, we're a managed care state in New York State, 80% of most of our population is in managed care. And you could see additional pressure being put on the plans to find savings. You could also see additional revenue being raised. So either new state taxes, or a fresh look at contributions from local governments. We've capped county and local contributions to Medicaid for a while now. And so there might be something that gets opened back up if there's a massive shortfall. But yeah, so I'm happy to, excited for the Q&A portion. I know this is a little bit doom and gloom of a presentation. I've given it a few times now, and I get a range of responses, but looking forward to having a chat about it.
All right, excellent. We'll move on to the Q&A then. So again, to those who came in a little bit late, as always, if you have any questions, just throw them in the chat. To get us started, I have not one, not two, but 6 questions we've been sent in advance. So I'll read the first one now. This person asks, what might be the impact to college campuses in New York State related to health policy reforms during Trump 2.0?
Maybe I'll tackle that one since it was more related to what I was chatting about. So So say what will be the impact to college campuses in New York State?
Yes, related to Trump's health policy reforms.
I mean, I think most directly, as I outlined, just the cuts to the NIH funding are, a way that all university, no university is really going to be spared from the impacts of this, especially, research active universities like UAlbany. For instance, I mean, it's just some things I didn't really get to go into, but the field of public health and medical care and our academic medical centers, they're largely funded on what we call in the field soft money, meaning basically like people have to get grants in order to be able to fund their salaries, and those grants also go to fund the research infrastructure that is part of the organization, right? So that's part of our universities, that's part of our academic medical centers. And so if, faculty aren't getting those grants, they may not be able to continue to have a job. And if they can't continue to have a job, then they're not going to be able to continue teaching. And, and also if those grants don't come in, then it destabilizes the finances of the universities and the academic medical centers, in a very profound way that can have, just huge ripple effects on those institutions, on the economy more generally. There's some other ways that it affects things, though. I think our ability to be a place where especially foreign students want to come is under attack in a wide variety of ways. I mean, one is just, if we're not going to be the center of sort of innovation and, we're known for having very robust universities, it's not as attractive to come here if, you don't think that you're going to have all of that research infrastructure. But then more specifically, some of these targeted cuts, like the ones at Columbia, for instance, have actually hinged on essentially turning in students who were protesters, right? So in order to, it's being used essentially as leverage. The threat of taking away federal grants is being used as leverage to be able to control what universities are studying, what faculty are teaching. One of the concessions that Columbia had to give up was to put its African Studies and Middle East, I forget the full name, department under academic receivership, and because that was a source of, I guess, a lot of the kind of support for the pro-Palestinian protests. And so, there's so many ripple effects, also like wanting to come here as an international student when you could be abducted on the street and sent to an undisclosed location in Louisiana, becomes less appealing, right? So I think there are just a wide variety of ripple effects that this can have on, academic freedom, scientific discovery and innovation. That is going to make us less attractive, less competitive, and make it just much harder for people to do the kind of basic research that, again, underlines all of the innovation that has made America, what it is, right? There was, I went to one of the protests against the NIH funding cuts. And there was one of the protesters had a sign. I said, I'm trying to remember exactly what it said, but it was something like, science is what made America great, right? And so, if science is under attack, I think, our status in the world is also under attack. So I will stop and take more questions, but that's my hot take.
All right, great. Thank you. Looks like the Q&A is off to an equally depressing start. Bear with me here. The next question is a little bit lengthy. Let me read this, though. While broad cuts across Medicaid will prove to be politically challenging, the administration's focus on budget neutrality in 1115 waivers will be another matter. In early 2024, New York State received approval for an amendment tied to $7.5 billion in funding over 3 years. How do you anticipate states like New York will account and demonstrate for budget neutrality and address any action by the administration that results in a funding cut for ongoing 1115 initiatives?
Good question. That's probably me. It's Medicaid. So yeah, the New York NIHER waiver, right? It's mid-flight right now. I work with a couple of the social care networks actually we're hearing everything we're hearing out of the state administration has been that that's safe so far. It's going to continue. It's scheduled to continue through March of 2027 right now. So that funding involves health-related social needs, right? It's an equity-focused waiver, has equity right in its name. So that was one that we were a little bit worried about. So I think that's going to continue. An extension is probably unlikely of that. I think had the federal politics shifted a different way, we would have been entering conversations right now about an extension. But we're seeing an extension as unlikely of that funding. The budget neutrality piece of that, I mean, that's a much longer conversation, right? I think, the 1115 demonstration waivers have a budget neutrality test that has long been maligned by the feds and appreciated by states. I think in terms of states having the ability, especially New York State, to accumulate a lot of savings against the target over decades and then do big splash expenditures like this one every 5 to 10 years. And that was under the Biden administration, they made changes to that where you can only count savings from budget neutrality for a couple of years back. You can only roll over so many of your savings. You can't basically have this blanket historical bank of savings that make sure you're always budget neutral. I haven't heard of this administration picking that back up. I know, as I said, I know Biden was had a couple proposals to tighten that up, a couple of state Medicaid director letters to tighten that up. But yeah, it'd be interesting to see if they do go after that.
All right, on to our next question. This person asks, will the Trump administration push for changes at SUNY for programs such as the Center for the Elimination of Minority Health Disparities, or will New York government be able to protect these programs?
I don't know any specifics. Okay. So, but I guess, I mean, one thing that I will say is, I'm a little surprised that NIMHD, I haven't heard, and anybody can correct me if I'm wrong on this, but I haven't heard. So NIMHD is the National Institutes of Minority Health Disparities. I think MHD gets their funding largely through that. It was an institute that was more recently created. And of course, it's the institute that funds research on health disparities. I mean, it's in its title, it's in its mandate. I haven't heard of that it's being eliminated. So that's good news, I guess. But it seems to me that it would kind of be surprising if that doesn't come up. And I don't know any more details than that, but that is the institute that funds research on health disparities. Cutting anything related to equity and disparities, is one of the main focuses of the government right now. So I'm kind of surprised that NIMHD is still standing, but anyone who's heard something different, feel free to chime in. I'm just trying to keep up with my LinkedIn feed to learn about what's happening.
So our next question asks if you could compare and contrast this current set of health reforms to the passage of the Affordable Care Act and its effects of our health system.
Do you want to try to tackle that, Roland?
No. I think, as I mentioned in the slide, from the perspective of everything Ashley talked about, there's a ton going on, right? From the perspective of Medicaid, at this point, it's a lot of hand wringing and worry, and not a lot of details in terms of what they're actually going to propose and do. And we have broad budget targets of savings they'd like to achieve, but not, all we have for the specifics of how they'll achieve them is things that we're sort of pulling and piecing together based on random comments. So it's hard to say. As I mentioned, I think one of the places they're going to continue to try to go is undermining the ACA explicitly, which means reducing coverage. They're also have a lot of comments, Dr. Oz in particular, about what they would call increasing competition within plans, what others might call pushing people out of these risk pools that really need coverage, right, and that are more expensive to cover, which is what a lot of the ACA did. And so I would expect some of those changes to come about too, but it's really hard to say until we see an actual proposal that has the details in it.
I might just add a little bit to that, and this kind of ties into Dean Navkov's question in the chat as well. So in Trump 1.0, right? One of Trump's big objectives was to repeal and replace the Affordable Care Act. There were elements of it that were kind of dismantled, but actually, that did not succeed. I mean, the way I see these, especially the cuts to Medicaid, is like this is essentially how you, repeal the Affordable Care Act without repealing the Affordable Care Act, right? And so, I mean, that's the way I see it. And so, Dean Novkov has a question about, like basically, will governors or will states oppose these Medicaid cuts? So a lot of the red states, conservative states, already have in place these trigger laws where, if and when these cuts come, they are going to like automatically repeal their Medicaid expansion because they don't want to take on the cost of paying for it. I mean, and these were states that were reluctant in the first place to kind of do the Affordable Care Act. I mean, they did it essentially because it got to the point of being ridiculous because the federal government was like, well, we're going to pay for all of this, for all of your people to have health care. And so to refuse it was like, it just became kind of ridiculous, right? And so they have, they slowly started adopting it, but now a lot of these states have these trigger laws. So I think it's going to turn into, another kind of red-blue rehashing of the politics around the Affordable Care Act, where, yeah, blue states are going to try to find ways to continue to cover their Medicaid populations, but red states are going to opt out, essentially.
Yeah, I want to piggyback on that because I saw Professor Novkov's comment as well. I think it really depends on the proposal, to Professor Fox's point. When you get into the proposals like the ACA population, the 90% match, I think you're going to find places where red states can cover themselves with trigger laws and other things where they're not going to have massive budget shortfalls, and blue states will be less able to. And I think that increases the likelihood of it happening because it sort of fractures the governor's resistance to it. With things like a reduction in the FMAP generally, right? So that was being talked about, the minimum is 50%, right, for a high income state. There was talk of that going to 40% or something like that. That got basically shut down, I think, by the governors. Mike Johnson made a public comment, I think, a couple of weeks ago. We're not going to touch the minimum FMAP as a response to some of that political pressure. So it really depends on what they're talking about. I think the provider taxes thing will be similar to the floor in that I don't think they're going to want to touch it just because, like I said, Texas makes tens of billions of federal dollars a year based on their provider tax program. And I could probably think of a couple other examples if I had 5 minutes to Google where they're making a lot of hay with those regimes. So that's going to be a tougher one. But yeah, I think proposal by I think we're going to find one of the pressure on this administration is going to come from governors, and we're going to see where they stick together and where they sort of split.
All right, our next question is very to the point. They ask, is there any hope left for single payer?
Well, I'll take that on because I'm a big single payer advocate. I don't really disguise that. So I mean, my hope of a silver lining here is that this could create a space where that could be back on the table. And I will just point out for people that are not aware that New York State has its own single payer bill, the New York Health Act, that has been around for quite some time. It started kind of coming up on the agenda and around 2018, 2019, then COVID happened and then it kind of dissipated. But I do think that these massive cuts to Medicaid, which is going to totally destabilize the state budget and require really difficult choices of like, do we like kick people off of Medicaid or do we raise taxes? Do we raise property taxes? Not very appealing. Could actually be a catalyst for looking at the New York Health Act. And there is a new financing plan that is hopefully going to be released soon that is looking at like, how would we finance this? But all of the estimates show that you could cover everyone, like from previous reports, you could cover everyone and actually spend less on healthcare. You cover everyone comprehensively and actually spend less on healthcare, and that there could even be enough savings to make up the difference in the Medicaid cuts. And in some ways, if Medicaid is block granted, or if we don't have to worry about federal waivers at all, then you have a free chunk of money that you can decide as your state, what do you do with this? So yeah, I think that it does create that opportunity. And actually, I am trying to set up a separate session, maybe just about that, but that's in the works.
Right, so I have one final question I got in advance, and then I see another question in the chat from Steve Keller. So I'll get to the next question. This one just asks for your thoughts on reference-based price initiatives similar to Maryland, Oregon, and Vermont.
Do you want to tackle that, Roland?
I think they're great if you can get them. That's basically my perspective. I mean, I think it's a good idea. It has a lot of promise. It's a little bit, I think, in some ways, the thing that I think about whenever we talk about really technical rate setting changes or sort of even just overall reimbursement change methodology in general at times like this is it cover, right? Is it cover for a broader objective, which is creating savings or expanding programs, right? And so one of the ways to really kind of expand your ability to impact programs is to fundamentally change how we pay for things. And so you can see political leaders do that at times of change and inflection points where they say, okay, we're going to put a whole new regime and it's going to be great because of all these technical reasons. But underlying that is a 10% across the board cut to what they were paying in the past or what have you. So that's what I would worry about. I worry about that with per capita caps and block grants too. I mean, those aren't terrible ideas if done, if maintaining funding levels in the process and putting good trends on them, right? In the process, but we all sort of don't buy that, right? That they would do those things. So I think it's similar. I think those are really good ideas. They could be better ways to pay for certain services. And Maryland's had success with it. But I worry about the politics sort of overdriving the technical administrative aspects of it at this time.
All right, moving on to what's probably going to be our final question today. So Steve Keller in the chat writes, how might New York State government react if there are reductions in Medicare benefits and/or mass transfer of Medicare enrollees into Medicare Advantage plans? I think Dr. Oz is a big proponent of this at CMS, so we'll see.
Do you want to tackle that, Ron?
Yeah, I haven't seen anyone come after Medicare in terms of just like blanket cuts in any proposals yet. It's actually going back to the Medicaid cuts. It's been encouraging to see the pushback, particularly at like town halls for Republican congresses and congressmen in blue states in New York in particular. They're getting booed. There's a lot of pushback. People have said things like, "Is Medicaid a third rail issue now?" Right, which is nice to hear. So if Medicaid is a third rail issue, Medicare certainly still is. In terms of Medicare Advantage as people being forced to transfer into Medicare Advantage, Medicare is sort of unique in that it has this robust fee-for-service program with ACO models in it, right? So you have, they still want care management, but there's care management in the form of an ACO versus a Medicare Advantage organization. Those ACOs have had a lot of strong constituents in the past. There's a lot of business people who have started ACO programs, including some folks that are tied in with the Trump administration and Dr. Oz himself. And those are only there because of the fee-for-service aspect of it. So I would be surprised to see, for reasons that I wish were more noble, but I'd be surprised to see it them make massive changes to the fee-for-service aspects of Medicare. Medicare Advantage is the dominant system. I think it's 60% of enrollees are in MA now. Maybe a little bit less than that, but still more than half are in MA. So it's definitely not going away.
All right. Well, we can wrap it up here. You can join us next time at Rockefeller College's Lunch and Learn series on Wednesday, April 16th. We're going to be joined by Myla Gasco-Hernandez and Ramon Gil Garcia. Their talk is titled Addressing the Risks of Government AI Initiatives Through Civic Engagement, the Role of Public Libraries. But thank you to our speakers today, and thank you for everybody who attended and participated. Really, this makes these events special. Thank you.
Thank you.
Thank you, everyone. Feel free to reach out with any questions.
Yes, same.
Thanks, guys.